Right, I hope you can see that clearly. If there are any problems, please do say. I'll have the chat up so I can keep an eye, but if you've got any issues at all, at any point you can't hear or you can't see, just let me know, okay? And I'll see what I can do about it. Okay. We're good to go? Wonderful. Right, so I'm Dr. Lolu, and today we're here to talk about bloating, and we've called it big belly blues, which is really just to, because it's something that really gets on people's, really worries people, and we really want to get to the bottom of it and help. Really, I hope by the end of this time we spend together, you'll come away with something that you'll find useful to be able to tackle bloating for yourself. So let's get going. And I really just want to start with a question. What would it be like to be able to enjoy your food again without worrying about the consequences? To be able to put on your skinny jeans for a day out and not have to, by the time you get to sort of lunchtime or maybe even by dinner time and you're sitting at the table, you have to like undo your button under the table, hope nobody notices. Or to be able to eat whatever you wanted to, within reason, obviously, without like going out for a meal with friends and not having to think, oh, what restaurant are we going to? What does this meal have in it? Will I be able to eat this without, getting bloated? And not to be sort of restricted by symptoms that you get with food. I hope that by the time we've spent 45 or so minutes together this evening, you'll come away with something to help you really help you start to really enjoy everything you want to eat within reason. I always have to add within reason, okay? So I'm going to go over today what normal digestion is, what happens when it goes wrong, and big belly busters, okay, which are tips that you can use to help ease your symptoms, okay? That's where we're going to start, okay? So forgive me if I keep looking to the side, that's where my admit screen is. So when I see people come in, I have to turn to that screen to let people in. So I'm not ordering my Amazon shopping on the side while I talk to you, okay? So a little bit about me before we get going. There we are, next slide. That's sort of my training and qualifications. I'm not going to read that out to you, but I thought probably it might be interesting. I always find it interesting to know why somebody would go into something like this. And yes, as you can see on the screen, and I'm an NHS GP, and I've worked in Ipswich in Suffolk for the last 8 years. But I've always found it, for me, my frustration began quite early in my time as a GP, when I would see patients and we were not getting to the bottom of their symptoms. And my patients I was frustrated, and my patients often, sometimes we'd go through we'd take the history and the examination and all of the things that we do in general practice. We would get to go all the tests and things that within the time and resource constraints of the NHS, and get to the end of all of that, and everything would be normal. And I'd ring the patient, or they'd come in for their results, and I'd say, "Good news, everything is normal. There's nothing wrong." But the patients would be like, "But there is something wrong. I don't feel normal. Everything is not all right." And we would be stuck at a bit of an impasse where I'd be like, "Well, there's nothing else I can test for. I've tested for everything." And it almost felt like I was leaving patients with a sense of hopelessness. They just felt like, "Well, now what? If all the tests say everything is normal, but I don't feel normal, what do we do next?" And often they would just be, "Well, manage." And that felt very unsatisfactory to me as a clinician. And certainly it wasn't the kind of the way I wanted to leave patients with, feeling like they had no hope and nothing else to do to help themselves. And then for me personally, it came to a head probably about 5 years ago, as a busy working mom, in the practice, 2 young children in primary school, and just always feeling exhausted. And of course, I went to my GP and I was like, "Of course, you're busy, you've got children, you have a job, and you've got a household. That's why you're tired. Okay, we'll do the blood test just to, pacify you." Of course, they were all normal. And I felt like I would not just accept that this was going to be the rest of my life, running around feeling, like I was running on empty. And so I started to do the research for myself to start. What can I do to make things better? There must be something that I can put into place. And as I did that, I started to find, I decided to expand my toolkit, essentially, with the extra training from the Institute of Functional Medicine in the US and the Society of Lifestyle Medicine here in the UK, finding ways and to things to apply to my own health, to actually not just improve my health from where it was as the tired mom, tired working mom, that the label that I've been given, but actually to even have more energy than I had before I had children and I was running around with my 2 young children, and before I'm working full time. And I realized that actually this was something I wanted to give to other people. And that's where this all started from. I would describe that really as what I would call my passion. It's helping people to understand and take charge of their health, to be able to look closely at the root causes of illness and root causes of symptoms, so we can change, we can affect those, we can make a difference to those to improve present health and reduce the risk of future ill health. Sorry, I just got to admit a couple of people. Okay, and that's why I started Paracletus Living Wellness, because that's our mission, is to rebuild and restore health, wholeness, and ultimately hope in individuals and families and in communities. And so that's the why. It's the reason behind all of this, and hopefully that makes some sense. The next bit is just what I have to do legally. It's a disclaimer to tell you that this class is educational in nature, and the information provided here does not replace medical advice, and it doesn't constitute a doctor-patient relationship, okay? Nothing here is all fluff and just pulled off the internet. It's all evidence-based, it's, from current research. But everyone's an individual, so you have to listen to it, utilize what interests you, do your own research, and throw away anything that doesn't serve you. I will not be offended, trust me, okay? All right, let's dive into it. Okay, we've done a bit of the preamble now, so let's talk about the agenda for tonight. What is normal digestion? Okay, that's where we're going to start. And actually, the very first bit of it, I'm going to just see, how much do you remember from biology class? So you're lucky, compared to those who were in the workshop in the face-to-face on Saturday. They actually had a piece of paper and they had to fill in what they remembered from number 1 to number 8. So if you start from the mouth, which is the nice obvious one, and just go clockwise, there's 8 arrows. I'll just give 15 seconds or so just to see, okay, that's too short, 30 seconds to see which ones you can name accurately, and see how you get on with those, okay? And then we'll keep going. And just while you're doing that, I like to think of, this is a slide I got from a fellow practitioner, actually, who she felt that it's really helpful to just, when you want to simplify digestion, write down to just the very simplest way to think about it. It's really all it is ingestion. You put the food in, hopefully not shoveling it in, which we'll talk about a bit later. And then digestion is smashing it up into small little bits. Absorption is picking out the good parts, and elimination is throwing the rest out, okay? And that's pretty much, if you divide digestion into its 4 basic phases, that's exactly what happens, okay? Now we can see your answers on the next page. Because we know that digestion, although that's a nice simple schematic that I showed you on the previous slide, it's actually a lot more complicated than that. Our bodies are wonderfully complex, created that way to be complex. And even now, we don't know everything there is to know about the human body. However, what we do know, we know there's a lot of detail that goes into our digestion. And it's important that we understand how it works, because then we know we can understand better when it goes wrong. So we'll just go through it just very simply from mouth all the way down to anus. I wonder if anyone, lots of people to admit. All right, so looking at the labeling. I wonder if you got everything right. You can pop it in the chat. We can congratulate you. It will be. It's interesting because these are things we think we remember until we look at the picture. Sometimes like, oh wait, what's that little nubbly bit called? And actually, digestion is really interesting. It starts long before it starts before you even put the food in your mouth. Okay, so just when I know might happen to you. It's happened to me certainly, where you just smell the food, that's cooking, or you're anticipating the food that's coming, and you're already starting to salivate. You're already starting to be prepared to receive the food. That's the beginning of digestion. And actually, the vagus nerve, which is is the nerve that I would say innervates the system of the nervous system that controls digestion, starts to fire off when we start to smell food. We start to think, well, I'm going to eat soon, and it prepares the body to receive the food. The very first bit of digestion that happens next is the mechanical breaking down of food, so chewing. And while we don't think often about our chewing, it's really very important, and many of us don't chew enough. So it gives the stomach a lot more work to do, because the food arrives sort of not even really broken down enough for the stomach to do its own job. But mechanical chewing and chewing, helps to break down the food. And in the mouth, the breakdown of carbohydrates starts first. So in the saliva, there's an enzyme called amylase, and that's where the breakdown of carbohydrates starts. And as that food is chewed and swallowed, speeds on down the esophagus, so the food tube. Our food spends very little time there if everything is working properly, lands in the stomach, okay? So in the stomach, the food just lands in a very, very acidic environment, and it's designed to be that way. The stomach makes hydrochloric acid, which makes the pH of the stomach between 1 and 2. So really acidic. And it needs to be that acidic because it does two functions, really, two main functions. There's probably more. One is to start the breakdown of protein. So it starts to break the bonds between the amino acids and break down the protein into smaller bits. And it also helps to sterilize the contents of what you've just eaten. So any bacteria or anything else that you've eaten, the stomach's job is to try and as much as possible to neutralize those agents, so those bacteria or viruses, anything you've eaten, so that it doesn't make it past your stomach into the rest of your bowel. Okay, so that's what's happening in the stomach. And as the stomach is doing that, it takes a few hours, but then what it starts to do is to spoon feed that acidic mixture down into the small intestine, just a little bit at a time. Okay, and that's really, so in the small intestine, the next stage of digestion, that's where the bulk of our absorption happens. The small intestine probably has the longest surface, biggest surface area of the whole intestine. It's about 15 to 20 feet long in most people. And it just fits into that bit that looks like spaghetti in the middle. But it's there that the food spends a lot of time. And the reason for that is so that all the good bits we want to pick out get absorbed. So that's really important. And there's a few things that happen in the small intestine. The one is that as soon as the very acidic food lands in the small intestine, the pancreas releases bicarbonate into the small intestine. So that very acidic food that we had now is mixed with the bicarbonate, which is a base. And I'm sorry if I'm giving anybody PTSD from chemistry class, but the acid hydrochloric acid mixes with the bicarbonate, and that neutralizes the acid so that the small intestine isn't full of acid. It's full of this nice basic, nice neutral mixture now. And then that allows other enzymes to start to work. The pancreas releases enzymes. The gallbladder, which you can see on the left-hand side there, the gallbladder, what its job is actually to release bile. So and it only does that when we eat fat. So its job is to help break down the fat, make the fat easier to absorb. So the liver makes the bile, stores it in the gallbladder, and when we eat a fatty meal, when it gets to the small intestine, the gallbladder releases bile into the small intestine to help break down the fat. So that's, although the food doesn't pass through the liver or the gallbladder or the pancreas, those are really important parts of our digestion. So the small intestine has three main parts. We won't really go into that today because that's a bit too much for what we want to accomplish. But the food passes through each of those parts. And then at the end of that, in the ileum, the last part of it, it then passes into the large intestine, or the colon, or the large bowel, whatever you want to call it. Now, the large intestine, in some ways, and in most people's view, is seen to be just sort of the conduit that moves, the waste around from one end to the other, and then out it goes, and that's the end of it. But actually, there are many more. It's a much more crucial part of the digestive tract than just the conduit for poo. Okay, so yes, it moves the poo around, and water gets absorbed, so that sort of the mixture becomes more solid and becomes more like poo. Yes, that's one of its functions. But actually, it's also the elimination function is really important. So anything like toxins or breakdown products of things that we've metabolized all get moved around in the colon and excreted. But probably the most important function of the large intestine is that it houses what's called our gut microbiome. Now, when I went to medical school, I wasn't taught anything, and that was not that long ago, not even 20 years ago. I wasn't taught anything about the microbiome at all. In fact, it would seem like nobody knew what was going on, but there was a lot of research, and that has since come out telling us about what the microbiome is and what it does. And we're still just scratching the surface of what the importance of the microbiome, because it includes about 500 species of bacteria, includes viruses, includes fungus, includes parasites, and they all live in our large bowel as good, what we call we tend to call them the good bacteria, but of course they're more than bacteria, but they're the good guys. They live there, keeping the peace, keeping everything working, helping us to extract nutrients from food that we can't extract anywhere else in the digestive tract. And there's shown to be quite a very strong link between what's going on with our microbiome and other parts of our body. So, and our nervous system, our brain health. You often hear people talk about the gut-brain axis, our immune health, our endocrine health. There's so many parts, so many different influences that the microbiome has on the rest of the body. So it's really important to have good colon health because we've got to keep those guys healthy and working. So, all right, that's the end of essentially what happens here is everything works and poo comes out of the rectum, or through the anus, into the toilet, hopefully. And that's the normal digestive system and the normal digestive pathway. So the next bit really is just, okay, that's normal. What happens when it goes wrong? And I'm sure we've all experienced something of that in our lifetime. What happened when it goes wrong? And as you can see from this picture, there's many, many, many things that can go wrong. There are many things that can go wrong at different points along the whole digestive tract. And we're not going to talk about many of these today. We're just going to focus on those that cause bloating because that's what we're here to do. And even on that, we're only going to talk about 2 or 3 or 4 of them. But the first and the most important thing I would say is ruling out the nasties, okay? And this is because there are conditions that can cause bloating that are quite serious conditions, okay? And those need to be ruled out, okay? These are things that on the NHS, your GP can very easily test for if they're suspicious from what you tell them. So if you've got bloating and you're worried about it, and that's why you're here today, but you haven't actually seen your GP to talk about, or your family doctor if you're not from the UK, it's really crucial that this is the first step. You make sure you've ruled out anything like that, like celiac disease, inflammatory bowel disease, which includes Crohn's and ulcerative colitis, ovarian and endometrial cancer. All of these can cause bloating. Okay, so it's important that those are ruled out first and foremost. The other thing that I want to touch briefly on is what we're not covering today, okay? So we are talking about bloating, but not about abdominal fat. And some people would say, that's semantics, Lulu. What difference does it make? And to be fair, both of these things can coexist. But bloating is different from just having excess abdominal fat in that bloating tends to fluctuate. So, somebody, they might have a normal waist circumference of 70 centimeters, and then they have, pizza for dinner, and their waist circumference goes up to 90 centimeters. Okay, so that might be a bit of an exaggeration, but the point is that it fluctuates. And the next day they might be back to normal. And then before their periods, they might go up again to 80 centimeters. That's more like bloating, whereas abdominal fat tends to be more or less static. So that's probably what I would say the difference is. However, it is really important that we consider abdominal fat, and we will talk about it in a different workshop, because it's really having abdominal fat or fat around our abdominal organs has been shown to be highly associated with cardiovascular problems like heart attacks and strokes, and has been shown to be associated with some kinds of cancers like colorectal and pancreatic cancer. So really important that actually this is something we need to talk about and deal with, it's just not in the scope of today's talk. So bloating, somebody is asked in the chat, can we describe exactly what we mean by bloating? So I would describe bloating as, an increase in the size of your abdomen or the size of your stomach, size of your abdomen, that can be related to having excess gas or excess wind or excess burping or excess flatulence. But the bottom line is that it increases your abdominal girth. I know people who, have flat stomachs, so it's not because they're fat, but they eat something, or it might be related to periods and hormones, and you actually see them and they look like they're pregnant. Their abdomen has come out so much, it's not subtle. Those are extremes, but that's bloating. Bloating is essentially your body feeling like it's full of your abdomen, feeling like it's expanded and looking like it's expanded without a very obvious reason why. Okay, so not like you've gained a lot of weight. Okay, I hope that answers that question. Okay, so going back to what happens when our digestion goes wrong, okay? And if you can identify with any of the symptoms I'm talking about, feel free to note them down, and we can have a chat about them afterwards, or if it might be something that you want to make an appointment to discuss with me separately if you don't feel like talking about it in public or we run out of time to talk about it, okay? But these are quite common conditions actually, so let's have a look at them together. Okay, so the very first one is something called hypochlorhydria or low stomach acid. And the symptoms, of course, include belching or bloating, but usually immediately following a meal, as opposed to the next condition we'll talk about, where it tends to happen a bit later. People often complain about a sense of fullness after they eat. The symptoms are often worse after eating meat or protein. Now, remember what I talked about earlier when we're talking about normal digestion, that the acid in the stomach is what's responsible for starting to break down protein. So if your stomach acid is low, so that pH of 1 to 2, if it's more close, more like 4 or 5, it can't be as effective in breaking down protein. So these people often will have, especially if they eat a meal that has a lot of protein in it, they often feel very uncomfortable. They can even develop an unconscious aversion to eating meat or protein because of the way they feel after eating it. And because that food can't get broken down quickly or sufficiently, sometimes that food is there so long, it starts to reflux back into the esophagus and they start to get heartburn, which is a bit paradoxical. Most people think about heartburn as, oh, it's because I've got a lot of acid, I've got high stomach acid, but this can actually happen when people have low stomach acid. And because the food isn't being broken down enough, sometimes undigested food ends up in the stool. And also, for people who have it long enough, you might start to notice symptoms that are a sign that the the bowel isn't absorbing the nutrients from the food sufficiently. Because if the undigested food passes into the small bowel can't do its own job, because it needs the food to have been broken down more to be able to absorb things like vitamin B12, iron, all the different things that are contributing to our body's normal functioning. So sometimes people start to get brittle nails or tingling in their hands and feet, or fatigue, and that's more of a because of the difficulty they're having absorbing their micronutrients, because the food isn't broken down enough in the stomach. Now, in terms of what causes low stomach acid, I would say the most common cause. There are other causes, and H. pylori infection is one. That's a bacteria that can be overgrown in the stomach, having the lining of your stomach not doing the job of making the acid. That's another problem. But the most common reason, is chronic use of medications like omeprazole, lansoprazole, pantoprazole, that we give out in general practice a lot, to help suppress acid in the stomach. And these medications, don't get me wrong, they are good medications and are often necessary. For some people, they are lifelong. For people who've got Barrett's esophagus or had gastric ulcers, or are on high dose steroids or anti-inflammatories, they need to be on a PPI, which is what we call them, or H2 blockers. Both of those are medications that reduce the production of acid in the stomach. And for some people, those are most crucial. They must stay on them for life. The problem is for those who don't need to stay on them, who are started on them for an episode and then just continue on them for months and years on end. And all that does is that it means that the acid in the stomach is chronically low, and they can start to get symptoms like we've described here. So how do we test for low stomach acid? It's not really that easy. There's no real, except in research labs, it's not easy to access the stomach in a non-invasive way to get a sampling of what's in there and test it to see the acidity. There are some things you can do as a self-test, and one really easy one is, again, forgive me if you hated chemistry in school, but this is a really simple chemistry. It's just, a little bit of bicarbonate of soda, which we often all have in our baking cupboards or our cleaning cupboards, a quarter of a teaspoon or half a teaspoon in 4 to 6 ounces of water, first thing in the morning, before you eat or drink anything else. Now, if you've got a lot of stomach acid, once the bicarbonate hits your stomach, you would expect that chemical reaction, acid plus base, would happen, and it produces carbon dioxide, which will make you burp, okay? Because your stomach's like, oh, all this gas has to come out, okay? If that burp happens within 5 minutes, then it's a sign that you've got good amounts of stomach acid. If you don't have one within 5 minutes, it may be a sign that you don't have sufficient stomach acid, okay? Now, this is not a perfect test by any description, and often there are false negatives and positives, but it's just one that gives an indication. There's also another test, which I won't talk about in detail, which is just essentially taking hydrochloric acid tablets. Again, it's not something you should try if you have an ulcer or any other kind of stomach condition, but I can talk about it in more detail with anyone who is interested. And because you can very readily get hydrochloric acid tablets as a supplement from most supplement companies. The other thing that can sometimes be an indication is that in conventional labs, so in conventional blood tests that we do in general practice, you might notice nutritional deficiencies in people who've had low stomach acid for a long time. For the reasons I described earlier, the small bowel can't absorb from partially digested food. So you might see people who maybe have low vitamin B12, and they've had supplements and it comes up a bit and then it goes back down, and it's just there, a chronic low grade deficiency, and that can't be explained, and nobody really has gotten on top of what to do except just try giving more supplements. That's often an indication that there might be something going on with the absorption that we haven't picked up. Now, here's another example here. So in this is actually from a stool test. So this is not something you can get on the NHS, But this stool test, the GI map stool test, is actually very informative. It has usually comes back with about 10 pages of information that's just really enlightening about what's going on in the bowel. Now, this is just one page, and here we are, the box that's highlighted here, it is showing us about the levels of protein breakdown. Now, why this is important is that it can tell us about these particular small chain fatty acids that you see listed here, valerate, isobutyrate, isovalerate. They only are seen in the stool when the protein is broken down by bacteria in the gut. Okay, so if protein has made it all the way down from the stomach, through the small bowel, down into the gut without being broken down, and then the gut bacteria break it down, it will produce these particular compounds, which when you then measure them in the stool, if they are above a certain level, that gives you an indication that you've got high levels of protein in your stool that are not meant to be there. They are meant to have been taken care of much higher up. So these are the kinds of clues that we look for that give us an indication to tell the story of, oh, this is probably low stomach acid we're dealing with. And then we can do things to help treat it. Okay, let's move on to the next one. I'm trying to keep an eye on the waiting room and on your questions. I wish I had two heads today. All right, the next one, small intestine bowel overgrowth. Okay, so small intestinal bowel overgrowth, bacterial overgrowth, sorry, or SIBO. This is another condition that can cause bloating. Now, compared to low stomach acid or hypochlorhydria, you don't get the bloating as quickly. So the bloating tends to happen after about an hour or two after eating, compared to low stomach acid, where it happens more within a minute. It's quite, but within minutes. It's quite, because obviously the stomach is more the food gets to the stomach before it gets to the small bowel. Okay, so that's the reason why the bloating tends to happen a bit later. People with small intestinal bowel overgrowth, essentially they've got bacteria where it's not supposed to be. Okay, so the small intestine compared to the large intestine is largely sterile. There shouldn't really be any bacteria hanging out there. Why? Because your stomach has killed off with its good acid most of the bacteria if you ate anything that has anything in it, and then the large bowel has its own bacteria in it, but the small bowel is nice and clean, doesn't deal with the bacteria at all. So if you get bacteria overgrowing in there, it does tend to cause a lot of discomfort. People tend to get a lot of bloating because the bacteria, as they work on the food, they make a lot of gas. It can make, depending on the type of bacteria, it can make people get diarrhea or constipation. You might notice fat in the stool or floating stools. Now, that always makes people laugh because they're like, who looks at their stools to see if they're floating before they flush the toilet? But you'll be surprised because when you ask people, they're like, oh yeah, that's true. I did notice that my stools were not sinking down to the bottom of the toilet like they normally do. But if you don't, people may not just think about it until you ask. But the reason why that happens is because the small bowel can't do its job as well as it's supposed to. So remember that I said that fat, when you get fat when you're eating fat and it lands in the small bowel, the bile is secreted to help break down the fat and then it can be absorbed. Well, if the small bowel's got all this bacteria growing in it, that doesn't happen as well as it should. And just like with low stomach acid, the small bowel then can't absorb all the nutrients, and you start to see symptoms from deficiencies in vitamins and minerals that are meant to be absorbed in the small intestine. How does this small bowel overgrowth happen? Well, one of the reasons is one of the things that can lead to it is having a lot of strong antibiotics that knock out everything else that's good. Another reason is and allows the bad bacteria to grow. Okay. Another thing that can cause it is if you ever have food poisoning. So you eat some bacteria, or eat something that has bacteria in it, and that isn't for whatever reason, maybe the load of it is too much for the stomach to really kill it off, and it can land in the small bowel. And some of those bacteria can stay there and continue to grow long after you think the symptoms of the diarrhea or vomiting that may have been caused by the food poisoning, those may be long gone. but the bacteria are still hanging around, causing problems in the small bowel. And there's other things. Actually, low stomach acid is one of the root causes, actually, of small intestinal bowel overgrowth, because of small intestinal bacterial overgrowth, because if the bacteria haven't been killed off because you've got low stomach acid, then they're free to enter into the small intestine and cause havoc. Okay, so lots of other causes. I won't go into all of them, but that's to give you a general idea of how this can happen. And it's very similar for this other condition, which is essentially the same thing, but fungus overgrowing. But the reason I wanted to highlight this is that sometimes the symptoms are slightly a bit subtle, there's a bit of a subtle difference between the symptoms. You might get some of the same bloating symptoms, but you might also notice fungal infections in other places. So, skin or nail infections, recurrent thrush infections. People often come and say, I've got itching, I think I have worms, and I've had taken worm treatment and it's not any better. I've got itching around my anus, and we look and there's nothing to find. Well, that is because there's not always anything. It might be because there's bacteria overgrowing on the inside. People complain of really bad itchy ears or really bad seasonal allergies that they can't get on top of. And this is one that's a really strong clue. People that have really strong sugar and refined carbohydrate cravings, often, not only that by itself, but when you look at it in the big picture, it could give you an idea of that there might be a fungus overgrowth in the system. Now, this is because fungus really, really love sugar. And refined carbohydrate essentially breaks down the body into sugar. So that really wanting to have sugar all the time is a really interesting clue into SIFO, or small intestinal fungal overgrowth. Oh, we'll just admit a couple of people, just a moment. Okay. So just wanted to really land this way, just giving you telling you a story about a patient of mine. So this is young Nancy. I have to say she's young because she's almost the same age as me. She's 46. I'm not quite 46 yet, but she was 46. And at the time when I met her, had 2 young children, was a busy working mom, and just was really struggling with bloating. It was affecting her job. So she worked as a teacher, and she would go to school and have her lunch, and before the end of the day, her stomach would be so bloated she'd have to undo her skirts. She would eventually, she just stopped wearing her smart clothes and was always wearing like big tops and stretchy pants, just because she never knew when the bloating would happen. She didn't always know what was causing it. So though she had a really long list that started from lactose in her late 20s, and then just added on one thing after another. She couldn't eat, couldn't have oats, can't have beans, can't have lentils, certain vegetables, rice when it's freshly cooked. And the list just kept going on. And she was getting to the point where for someone that really loved food, she was getting really frustrated. She had tried some things on her own and wasn't really getting any better. So she came to see me, and we sat down. The way we work in Paracletus Living and working with, using functional medicine principles, a lot of what we do is listening. Really, we're just listening to what has happened, because I feel, and this is probably the case, that most of the time, for all of us, our bodies tell the story. It's just, are we listening? Do we have enough time to listen to the whole story? And actually what we do in functional medicine, we start the history from before you are born, before she was born, what happened antenatally, what happened to her as a child, when was the last time she felt well, and what were the events leading up to that. And then we take a really probably the first 60-minute consultation is probably 45% of that, no, 45%, 45 minutes or 75% of that time is spent just me asking questions and listening and noting where things, and before you know it, you start to see the jigsaw puzzle come together. And for her, she grew up in a culture where it was very easy to obtain antibiotics. And when she was growing up as a child, her parents didn't know any better. Any little sniffle or anything, she would get antibiotics. And so she was exposed to recurrent, antibiotic courses as a child. And then probably in her, her 20s or so, she what's that one? No, in her 20s, she got married, and in about during her honeymoon, she developed she got food poisoning. And she would say that that was the last time she felt that her body, her digestive tract felt normal to her. That after that time, she began to notice she got more and more problems with her digestive system. And then probably the last clue that really helped me put it together, I think I know what's going on here. She had a neck injury, probably sometime in her 30s, and she had been put on naproxen, which is an anti-inflammatory, and needed the omeprazole or acid blocker to reduce her risk of the naproxen irritating her stomach. And so she had it for that, 2 or 3 months. And then the naproxen stopped, her neck was better, but she stayed on omeprazole for such a long time. She just thought, well, this makes my stomach feel so much better. So she took it preemptively or prophylactically. She just took it every day because it helped her feel better. And she was on that for years, on and off. So that gave me the clue that this probably is small intestinal bowel overgrowth. And so what I did for her was I did a breath test. So this is a SIBO breath test, which is very non-invasive and you can do at home. All it involves is just taking a bit of lactulose, which is most of us know lactulose as a laxative, but in this case, it's used as a substrate for the bacteria in the system. Because if there is bacteria sitting in the small bowel and the lactulose hits the small bowel, those bacteria will make gases that can be measured. So hydrogen or methane gas are the main two ones that are measured. And essentially there's a baseline measurement, and there's the gas is measured, or the breath samples are taken at time intervals. And then we look at what the expected level should be, given if the bacterial levels are normal and if the bacterial levels are overgrown. And for her, you can see down here in this box that's red, she had high levels of methane gas, which told us that there was this particular type of small intestinal bowel overgrowth, which is the bacteria that produce methane. That was the kind of small intestinal bowel overgrowth that she had. And that was, once we were able to nail that diagnosis, then it made it much easier to address it, because we could look at, okay, what's the cause? Why is that bacteria overgrown? How can we use the framework, which I'm going to talk about in our tips section, going step by step and designing a protocol for her, looking at what foods that we were going to, that she needed to have, what things perhaps we need to take out of her diet for a short time, whether any nutraceuticals or botanicals or supplements were going to be helpful to support her system. And we did this. It took about 3 to 6 months, but actually by the time we were done, she had a lot more on her list that she could eat. I mean, she was still lactose intolerant, but that was probably genetic, and there wasn't much we could do about that. But everything else was much better. Her bloating had improved considerably. Her mood had improved considerably, and she was much happier. So that's an example of small intestinal bowel overgrowth. I just wanted to show this as a snapshot really quickly. This is another patient of mine who actually had small intestinal fungal overgrowth. And this is a test. This one is actually a urine test. Again, not available on the NHS, but it is a very useful test because it helps us, it's an organic acid test, and helps us measure metabolites of, let's see, there we are. It helps us measure metabolites that have passed through the body, are not absorbed by any part of the body, and they end up in the urine. Okay, and when there's high levels of fungus in the body, you can measure some metabolites that give us that indication. And this person, I won't go into her history, but essentially one of the clues for her, though she came to me with fatigue and brain fog, and she thought it was menopausal, and she'd been on HRT and it wasn't getting any better, or was only a little bit better. But when I took her history, one of the clues were that she'd had repeated antibiotics for UTIs as a teenager. And now she still struggled with recurrent thrush, although she was not diabetic, and she had such strong sugar and alcohol cravings, even though the rest of her diet was perfectly good. really good diet, but she'd always, every night, she'd say, okay, she's done for the night. And then at 10 o'clock, she'd have half a bottle of wine and a chocolate bar. And she just couldn't understand why she couldn't get on top of that habit. So what we did was we focused on her bowel. We focused on getting the fungal levels down, and that improved her symptoms. But we won't be able to go into all of the details because I want to honor your time and finish on time, okay? So let's speed along here. Constipation. Oh, this is one that I think we have normalized in our everyday, we just think it's okay. For most people, they eat every day, twice, 3 times, 4 or 5 times a day. And you ask people, well, how often do you empty your bowels? And they say, well, once a week or twice a week, but that's normal for me. Can I just say that is not normal? If you eat every day, you should at least be opening your bowels once every day. And as we talked about earlier, there's the reasons why you want to get all those toxins out. You want to get the waste out. You don't want your microbiome to be affected by the fact that you've got all this poo sitting in your bowels for 48, 72, 96 hours. That's not normal. And if it's happening, we have to think about why it's happening, because it can cause other symptoms further down the line. And I won't go into this in a lot of detail, except to say that it needs, when we see this, we can't, it's not something we ever ignore, because it needs addressing. Even if you've been like this all your life, I guarantee you that when opening your bowels more frequently, working on how we get to that stage, it will improve your health, hands down, even if that's all we ever do, okay? So lots of reasons, lots of causes. We won't talk about those today, so we can get to the tips, because I want you to be able to take something home today and you can put into practice tomorrow if you want to, okay? That's another page from the stool test that I talked about earlier. Like I said, that stool test is about 10 pages long, and it's full of information that gives you action points. And you can see even here, this is telling us about the bacterial balance in the gut. This biosis is telling us about, and it actually gives you some tips about things you should do to help improve that, so that your gut bacteria are more balanced. But we can always talk about that another time. Ooh, we've gone back too far. Okay, so let's get on to the tips. I call them big belly busters. What can help to ease your symptoms? Because that's what we want to get to. Okay, and I was talking earlier, and I've meant to talk about it now. We have a Paracultus Living, we call it a big belly buster protocol, but it's not really unique or new to me or to the practice. This is a framework that the Institute for Functional Medicine uses and teaches to help think about how do you address gut problems in a way that is comprehensive and looks at things from all angles, okay? And it's not a bog standard one size fits all protocol either, because everyone's different. Like I was trying to demonstrate with those patients, the symptoms might seem similar. It might just go, everyone's bloating, but actually what's causing the bloating? Okay, and then from working out what we think is the underlying cause from the clues we can work out from the history, then we can either, if we're going to do some testing, we can do some testing to help, nail the diagnosis. Or if we're reasonably sure, we can move on to doing some of the working through this framework for that particular person. So it's always personalized. It's never just just take this off the shelf and hand it to you, you go off and do that. It's always about where that person is and what symptoms they have. And I'll mention this as I go along. The first part, so the protocol is remove, replace, reinoculate, repair, and rebalance, okay? So the first tip here is remove. And the example I want to give you from here, because there's many things we can talk about in terms of removing anything that stresses the GI tract, but food is the most obvious one, okay? Because when you've got food anything in our diet that goes into our digestive tract that doesn't agree with our digestive tract will cause stress, will cause symptoms. And the most common way of trying to work that out is an elimination diet, and the way we tend to do it is we would usually, for most people, say, 4 to 6 weeks, where we remove the most common stressors of the GI tract, because it's not always obvious what it is for every person. But if we spend 4 to 6 weeks to first take everything out that might be stressing the digestive tract, give the digestive tract the chance to heal by feeding whole foods that are low allergenic, and give people satisfaction. So not eating just grass and cucumbers for 4 to 6 weeks, but good food, just less allergenic food. And then as the gut, given that you got a chance to heal, we start to reintroduce things one after the other, giving the body a chance to see, okay, is this okay? Do I get any symptoms when I add flour back into my diet? Oh, wow, my joints start to hurt. Well, actually, maybe that's not a good one for me. And taking that back out. So an elimination diet is a tool we use quite often. It's quite personalized. Some people, who are coming from, really awful diets find it really hard to go straight to elimination. So we might start with something where we, gently bring them to a healthier diet. And then we move after a few weeks to more of an elimination diet, or we eliminate one thing only if from their history it seems like maybe that's the one thing causing problems. We work it out based on where people are. So it's never just that you have to go and do all of these things. And there's all the way through at every step we're supporting to make sure that you're able to do it with really practical tips, to not just here's a sheet, off you go. So that's the remove. We remove things that might be stressing the GI tract. Replace. So that's replacing anything that is required for proper digestion that might be missing. So we talked about this with low stomach acid. You can replace if someone's got low stomach acid, while we work on what the underlying cause is, we can replace the stomach acid. There's supplements of hydrochloric acid that are available. There's digestive enzyme supplements that are available. So lactase, pepsin, various, pepsin digest protein. So various supplements that can be used to replace digestive secretions in the short term, while we work on the underlying cause for it to be low in the first place. Of someone who's had a gallbladder removal because they've had gallstones or an infected gallbladder, we can replace the biles that they've lost with they're not getting that sort of concentrated bile that the gallbladder produces. We can replace it with bile acids or bile salts. So there's various things that can be replaced to help improve digestion based on what the person's story is. Reinoculate. So we encourage the growth of healthy bacteria by reintroducing the healthy bacteria into the gut to try and restore balance. And we can do that through probiotics and prebiotics. The probiotics are the actual bacteria. So foods that contain the actual bacteria, because they are fermented foods. So things like yogurt, miso, tempeh, kefir, sauerkraut, things like this that are made, some in Africa, we've got some naturally fermented foods. These have probiotics, these have good bacteria in them. And you can eating more of those foods helps introduce those bacteria into our gut. And then the way we help to maintain those bacteria is by feeding them with things that help encourage their growth. So feeding them the food they like. And those are prebiotics. Okay, so that's giving the bacteria, the good bacteria, the food that they want so that they can develop more in our gut. So again, there's a list of foods where you can, that are prebiotics and are good for the gut bacteria. Both of those, probiotics and prebiotics, you can have in supplement form. But I always like to encourage a food first approach, not only because, it's more, to me, I feel it's more natural, but it's also in many ways cheaper than supplements. So if we can get it in food, I often encourage that. If you feel like, well, I'm struggling with eating all these new foods or different foods, then a supplement is perfectly fine in the short term. So that's re-inoculating. And there's a handout actually that I would like to share with you that's got a lovely list of probiotics and prebiotics. So what I'll do is when I send out the recording, I'll send that handout out as well, because I think it's a useful one to stick on the fridge, or we can take a picture and have it on your phone. So when you go shopping, you can pick up a couple of things to try, especially if some things on here are new to you. Okay, repair. So we want to repair the gut lining. Okay, And that's just by making sure that the key nutrients that supply the gut lining are available in our diet. And often this has to be often with supplements, okay? All right, rebalance. This part is the part I feel most people don't pay as much attention to. And I have been guilty myself, because it is looking at the lifestyle factors that surround that enhance our digestion and working on those, okay? Because we know when we're stressed, we're in the fight mode or flight mode, our other system that helps to rest and digest, which is the parasympathetic system, the vagus nerve controls, that is not turned on when we're stressed. So, eating at our desks quickly when we, have to, between patients or between meetings or whatever, that's not good for our digestive system. So it's about slowing down, paying attention to our eating, chewing slowly, as many times as you need to, taking in everything, no TV, no electronics, no computer screen, and just really enjoying our food. It's hard. I find this really difficult, even now, because I'm always on the go to do something, but it's really important. It makes a difference to our digestive system. And then for those that suffer with constipation, it's about retraining your colon. Hanging on to poo for 4 days is not the thing. So spacing meals to allow time for full digestion, having a routine that allows time for relaxation, and a bit of exercise in the morning, even if it's a 10-minute walk around the block, that's really good to stimulate a bowel motion. Lots of fluid, lots of fiber, and lots of things I can't go into because we're out of time. But it's a really important one to pay attention to. Okay, this is all what we've covered today. What's normal digestion? What happens when it goes wrong? What are the things that can help to ease your symptoms? Well, and we've talked about some tests. We've talked about some tests that aren't available on the NHS, but are often very useful pointers. And you may be wondering if any of them might work for you. I've a little gift for you, which is a quiz that I wrote. Takes about 15 to 30 seconds, so it's not really that long of a quiz, but it helps to, if you just go through it and tip any symptoms you've got, it will help you to work out, you might point, so this test might be helpful, this is what it does, this is the information you get from it. And then you can decide, yeah, maybe I want to find out more or not. And if you do want to find out more, you can book a call with me for 15 minutes, it's no charge, completely free. You can book it on this link, both of the links. So this link with the test chooser and this link for the call will both be in an email in the next few days. So you can, if you want to wait for that, you can, or you just take a picture of the screen and you can go on to use the QR code to get there. And as an extra bonus, for the first 5 people who sign up today, I'll extend that to 30 minutes. So if you've got some complex digestive things you really want to talk about, and again, it's free. So, 30 minutes free of my time for the first 5 people who sign up. I gave the same offer to the Saturday people and it was snapped up. So if you want to be,
this is a reminder.
Ignore my Alexa. All right, then that's your opportunity. But that's also my reminder that I'm done. So if you've got any questions, please do pop them in the chat or put your hand up. I'm happy to take your questions now.
Wind down devices off.
Sorry if that was a bit of a whistle. I feel like I was speaking really fast and you had so much that I wanted to share. I wanted to make sure we got through everything. So forgive me if I went through things too quickly. Like I said, I'm more than happy to have separate conversations with people. If you want to ask questions now, I'm happy to take questions. Otherwise, we'll call it a night. Oh, I'm glad you found it helpful. I'm really glad.
Hello.
Hello. I can hear you.
Hi, sorry. Yes, okay. It's just a quick question because obviously, like I sent a message, I was driving and I was listening and concentrating on the road and whatnot and not what. So is it possible to have a printout of what you've done or a recording so I can listen to it? Because there are one or two things.
Of
That piqued
course.
my
So
interest.
yes. So what will happen is I will so this was recorded. So once we
Oh
finish,
yeah.
I will need to probably polish up a bit of preamble at the beginning. But I'll send out the recording,
Yeah.
send out all the links that I've
Okay.
wrote here, and I'll send out the probiotic and prebiotic handout at the same time.
Okay. Okay. Thank you. That would be great.
No
Thank you
problem at
very
all.
much. Thank you. This was really, really good.
Thank you.
Yeah.
Yeah. I posted a
Thank you for your
question
time.
earlier. I don't know if you saw it.
Let me have a look. So was this the question? Okay.
Yeah.
Is there much to be said for a simple diet as opposed to lavish rich meals? Okay. So yes, there is something to be said for simplicity, but simplicity is boring. I'm only speaking as a foodie here. I love food, in case you haven't worked that out. So yes, there is something to be said for simplicity, but the reality of the situation is that even in simplicity, you can find you will find that people still struggle if they've got digestive imbalances in any way. Even what we think is simple, from people who've got, let's say, SIBO, will find that difficult to manage. So it's not so much about simplicity, it's about finding what works for your body. And if that's, and I think for me, and that's maybe a story to tell another time, I found that actually I used to use food as entertainment. So I was always wanting food to excite me and entertain me and to be new and to be different. And that sometimes was a challenge. And that, led to me sometimes making decisions that were not the right ones for my body. And actually reframing that to food is for fuel and not for my entertainment has been a helpful thing for me. To sometimes I'm just like, okay, tonight really all I'm going to have is a simple side salad and some lentils, and that's good enough because it is fuel. It will fuel my body. My body will be full. I might not, my taste buds might not be entertained on this occasion, but it will be fine. And it doesn't mean it doesn't have to be tasty. It might just not be a variety of all the things you might want to eat. So there is something to be said about how we think about food as well.
Okay. Thank you.
Okay, no problem. All right. I don't think I've got very many more questions. I've got one from Dorothy. I think probably the self-test, what I would suggest would be to, if you have a look at the quiz. Oh, the self-test, the bicarbonate one. I can go. So the bicarbonate one is just the bicarbonate of soda, 1/4 or half a teaspoon in 4 to 6 ounces of water on an empty stomach, probably maybe first thing in the morning or 3 hours after your last meal. So that's the bicarbonate of soda one. The betaine one is a bit more complex and involves you buying a bottle of hydrochloric acid supplements to try. So I can explain that one to you if you want to speak to me privately about that. And I obviously would have some caveats around that because you're going to be having acid tablets, okay? So we don't want you to have anything that would cause you to have any symptoms. And yes, I will be addressing the issue of visceral fat. It will be probably, I don't want to promise, but it will be sometime before the end of the year. So I know we're in June, but it will be I would say likely this summer. If not, it will be sometime early in the autumn for the visceral fat tutorial. All right. If there aren't any more questions, thank you so much for coming to hang out with me for an hour. I really appreciate the fact that life is busy and you made time to be here. So thank you very much and have a good evening. I hope to hear from some people who are going to make an appointment for a call, but otherwise, I hope you've learned something and you've taken something away. Have a good evening, have a good weekend.